Today's June the 4th. This is the Adult Cardiac Surgery Database monthly webinar. We're glad you're here. So today on the call with me from the STS, I have Emily Conrad, Paul Meehan, Sydney Clinton, Carol Crone, and we have Melinda Offer. Today, our agenda, we are going to go over some important dates. We have a couple of STS updates, and then Melinda is going to talk us through some training manual updates. We will go ahead and begin with our timeline. So today, again, is June the 4th, our monthly webinar. June the 18th, we have canceled our quality improvement webinar for that day. More to come on that. We also have canceled the July 2nd monthly webinar. Our next time together will be the Quality Improvement Series on July the 16th. And then moving on to August, just want to put it out there that Harvest 3 close will be August 22nd. This will be a star rating harvest. Its surgery dates July 1st, 2022 through June 30th, 2025. And then the opt-out date for Harvest 3 is August the 26th. And you'll notice I have a time here. We are going to be changing the opt-out close time to 5 p.m. Eastern time. This is to give IQVIA and also the Research Center a little more time getting our data ready for reporting. So here is the 2025 harvest schedule, which you can find on the website. And again, you can see Harvest 3, harvest closes August 22nd, and then the harvest opt-out date with the closure time at 5 p.m. Eastern time has been updated on the website. So just keep that in mind. If you need to opt out, do so before 5 p.m. Other important dates, AQO 2025. It's coming around fast. We will be meeting in person in San Antonio, Texas at the Grand Hyatt Riverwalk, September 25th and 26th. The adult cardiac sessions will be Friday, September 26th in person. We will also have a virtual option. Congenital and thoracic will meet on the 25th. And then the Intermax and PDMax sessions will be virtual only on the 23rd of September. Cost information is coming soon, as well as registration. That will be coming soon. We've been busily trying to get our agenda in order. We pretty much have that set. It's going to be a really good agenda. We hope that all of you are able to attend. Emily, do you have anything to add?
There's 2 questions about AQO, so I'll just answer those now if you want. How will selected posters be presented at AQO? So we are going to have both. We are going to bring back in the in-person posters, and we're going to have an area for that near the exhibits. And then we will set aside some time for our poster presenters to be able to stand next to their poster and give presentations. And then we do have a virtual platform. So for our virtual attendees, we would want our we would want our poster presenters to also upload a virtual or a digital copy of their poster so that those attendees can be able to see it as well. So having it in both places. Will there be early bird AQO prices? There will be early bird pricing. We will be able to provide that. I'm hoping either later this week or early next week. We're just finalizing one detail prior to registration opening, and Nancy, Melinda, and I are working on that. And we're going to talk about it tomorrow, so that'll be ready to go. Do you have an estimate on cost? We'll be able to post that shortly. Kelly, if you want to email me, Emily Conrad at sts.org. I can provide you an estimate. Thanks.
All right, thanks, Emily. All right. And Emily, I'll just hand it right back to you to talk about the upcoming audit.
Yeah, so I handle AQO in the audit if anyone ever has questions about either. So we have been working with our audit company. We're working with the same one again, Healthcare Management Solutions. They did the audit the past couple years. We're working with them again. We will be starting the audit very soon. I hope to be sending the notification letters to our selected sites either tomorrow, Friday, or early next week. And then we will be having audit webinars for the sites that are selected the week of June 16 through 20. There'll be information about the webinar date for you in your notification letter. And I will also send a reminder email about the date as well. The audit this year, I wanted to mention that it is the same as prior years, but we also are going to be looking at aorta variables this year. It'll be 13 variables and it will be 5 cases. And as you know, not everyone does aorta cases. So in addition to, being randomly selected for audit, you also there will be like a second layer of random selection of who is going to be doing the audit for the aorta cases. Um, that will not, the aorta cases are not part of the um, audit policy. So anything with those, there would be no, it won't affect your audit scoring at all. But we are starting that as this section has been in the database for a while now. I don't know, Carol or Nancy, if you had anything to add about that.
Yeah, I can jump in. So we've added the aorta variables just so we can gauge where we are as far as what education we need to provide prior to the aorta risk model going live. The portion of the audit that involves the aorta variables is non-punitive. It's there for education purposes so that we can get everyone up to speed for when we start analyzing the aorta cases.
Yep.
Carol.
And I'll just add in, thanks, Emily and Nancy, you covered it well. This is Carol. The aorta section will be separate from your overall score sites results for your audit. So we'll provide you a separate score so they don't impact for this year, they don't impact your overall scores.
Thanks, Carol.
Mm-hmm.
We've got a few audit questions, so we'll go ahead and knock those out while we're here. So sites are notified by email if they are selected for the audit. And I believe it is the primary data file contact that is notified as well as the surgeon representative. Is that right, Emily?
That's correct. And the email will come from me, Emily Conrad, econrad@sts.org.
Just make sure that your participant contacts are up to date. That will be helpful.
Yeah.
And Hannah is asking, can we send out the aortic audit fields?
The aorta, all of the aorta fields, I'm sorry, all of the audit variables, including the aorta variables, will be updated on, we have a web page on the STS, I think under the resources, it says audit. You have to log in similar to when you log in to get to the data collection form, but we put all of our audit information in there. We haven't updated the instructions and the audit variable lists yet, but they will be updated very soon. So I would say within the next, 2 to 4 weeks, even if you're not being audited, if you click on that link on our website, you'll be able to see all of those.
Great. Thanks, Emily. All right. Just a few more STS updates. So the following documents have been updated. The June training manual has been posted. We have also posted the Harvest One multiplier table. That is on the website under resources for data managers. And then I wanted to mention again on the IQVIA library, the Harvest One composite quality rating summary is posted. I get a lot of questions about this. This is the document that talks about how many, or it talks about the quality ratings from the last harvest, and it gives you a percentage of how many sites got 3-star ratings, 2-star ratings, and 1-star ratings from all of the composites. A lot of surgeons request this information, data managers as well. So that is posted up on the IQVIA library if you're interested. And I wanted to just review quickly the multi-procedural composite. As you know, this is new reporting that came out with the Harvest One data. Still getting a lot of questions about what is actually included in multi-procedural composite. So I've listed the following procedures. It's all of your isolated or analyzed cases. So your isolated CABG, AVR, AVR plus CABG, your mitral valve repair and replacement with or without CABG, and then your multi-valve with or without CABG. That is what is included in the composite. Also, just noting thresholds for star ratings. Get a lot of questions about that as well. The National Report Overview, which is in the IQVIA library, is an excellent resource for this information. The minimum data thresholds by procedure are in this document, but I have them listed here for you. 50, a site would need 50 CABG cases to qualify for star rating, 10 AVR, AVR plus CABG, and then for your mitral categories, 36 for your mitral valve repair and replace, and then 25 for your mitral valve repair and replace plus CABG. Multi-valve and multi-valve plus CABG, there are no minimum data thresholds. And then for multi-procedural, you need 100 cases across any of those procedures listed. And then keep in mind, you must have 2%, less than 2% missing or unknown for all of the mortality fields, and 5% missing, less than 5% missing for your medications. This is for your CABG cases only. And then you must have submitted new data within the most recent quarter for Harvest 2 and Harvest 4, or the most recent 2 quarters for Harvest 1 and Harvest 3. I see someone wants to go back to the multi-procedural slide. So here we go. All right. And I also wanted to touch on the database endpoints. We get a lot of requests for this information as well. And I know we talked about this on our data manager training webinars, but in case you missed it, the risk model endpoint chart is found under resources for data managers under version 4.20 for adult cardiac, and then it is under additional resources. And this risk model endpoint chart is a really great resource for determining your numerators and denominators for your database endpoints. These would be your operative mortality, stroke, renal failure, and then also major morbidity, then your short length of stay and long length of stay. So that information is on this document. And then we also have the NQF endorsed measures document. This is where you find information about your the quality measures. So this document is a good resource for inclusion and exclusion criteria for your risk-adjusted measures. So operative mortality, wound infection, surgical re-exploration, stroke, prolonged vent, renal failure, use of IMA, your medication measures, and then your antibiotic measures. And then I just have some reminders for exceptional risk. So the exceptional risk exclusion request is found under resources for data managers. There's an online form that is to be submitted if you feel like you have a case that is not adequately captured by our risk models. Just a few reminders about that. Only isolated cases are considered for exclusion. So think your isolated cabbages, your isolated valves, valves plus cabbage. So we're not looking for aorta cases here as of yet. So just your isolated or your analyzed cases. All requests must be submitted prior to surgery. And you want to submit cases, again, that are not adequately captured by our risk models. Just remember to be sure that you redact all of the PHI in the record, and this includes surgeons, staff, and your hospital identifiers as well. I know a lot of the, I'm pretty familiar with Epic, and I know that on those records, there's sometimes a banner at the top that has the hospital name on the document. So we don't want to be able to see that information. We want the surgeon reviewers to be as blinded as possible. It really needs to be a confidential process. Also, cases that are submitted for exceptional risk must be entered into the database and submitted for harvest. So just keep that in mind. And then also it's important to make sure that you provide the correct patient ID and record ID. And these numbers are numbers generated by your vendor software, and they're usually found in the demographic section, and they begin with a V, the letter V. And then finally, decisions are made around the time of harvest close or just prior to analysis. And you will receive an email from Carol or me letting you know if your case has been excluded from analysis. All right. At this time, I'm going to hand it over to Melinda. She's going to take us through this training manual update.
Thanks, Nancy. So we had a training manual update just in June, and this is kind of a follow-up from a discussion I guess we had a couple months ago on one of these webinars. So after discussing this with Carol and Nancy, we decided that we would update the training manual. So I did want to point that out. So we're going to be talking about sequence 1966. STS risk calculator score was discussed. Previously in the training manual, we had language that talked about the STS risk models that were available. And so we were only using the risk calculator for the procedures that had risk models available. But after having discussions with Carol and Nancy and the advent of lots of new risk calculators, we decided that we would update the wording in June, which we did. And so the next slide. Okay, so here's how our update reads. Update June 2025. STS risk calculators are available for, and we go through and we list the different types of risk calculators that we have. So we have the ACSD operative risk. That's the original risk calculator. That's the one when we originally wrote this in the training manual. That was the only one we had. Okay. And that includes your cabbage, your AVR plus cab, your MVR cab, your MV repair cab. But since we originally wrote this years ago, we have come up with lots of new risk calculators. So we have a multi-valve surgery risk calculator now. So if you're doing an AVR plus an MVR or an MV repair, you could use that calculator. If you're doing a cabbage plus an AVR or an MV replacement or repair, you can use that calculator. We also have an isolated tricuspid valve surgery risk calculator. So if your patient is having a tricuspid valve replacement or a tricuspid valve repair, you would choose that calculator. We have a SAVR after TAVR risk calculator now. So these are for patients that had a prior TAVR and now they're going to have a SAVR, a planned SAVR. In addition, we have the new ascending aortic root surgery. We have the root plus ascending plus the valve sparing root and ascending calculator now. So that's basically your aorta calculator. And we also have a calculator for mitral regurgitation, which is surgical repair of primary mitral regurgitation. So we have lots of different calculators now. So we updated the language to say that, yes, we have all these different calculators. And so when you are discussing the risk calculator with your patients now, you can include any one of these risk calculators that you're doing for your procedure, and you don't necessarily have to have a risk model anymore. Used to, we had a risk model. Those are the only cases we talked to the patient about the risk calculator. Now, if you have a risk calculator available for the procedure that you're doing, the planned procedure that you're doing, then you're going to want to discuss that particular risk calculator with your patient. And then for all the other procedures that you may or be doing and there's no risk calculator, then those are the ones that are going to be coded as NA. So there's no risk calculator anymore, or it's an emergent or a salvage case. So next slide. So when you go on the STS website, you can find all of these adult cardiac risk calculators. You can see that they are laid out nicely for you. You can learn more about them, or you can even try them. When you pull a calculator up, it will give you, the very first question is like the type of procedure you're doing. So you can select, what type of procedure. So like if you pulled up an isolated tricuspid valve, it would want to know probably if you're doing a replacement or a repair, and then you'd go through and answer the questions. I also provided the link there. If we have time, we perhaps could go and show you where these are in case you're not familiar with that. Next slide. So in addition to the new wording, we also had to update the choices for sequence 1966. So the not applicable choice used to be for emergent or salvage cases, or no risk model was available. Okay, so now how it reads is not applicable, emergent or salvage, or no risk calculator available for the procedure. So if you have a risk calculator that's available for your procedure, the expectation is to use that calculator and have that discussion with the patient prior to going to surgery and talk about the risk. Next slide. So I want to go through just kind of a couple of FAQs that I get a lot about this particular sequence number. Here's just a one I got recently, but this is kind of a common theme. We had a couple of thoracic surgeons that have covered for our main surgeon, and they didn't perform the risk calculator score. When you answer no to this question, how does it affect your star rating for the CABG patients? Well, the first and most important thing here is that this is a MIPS reported variable. For people who do MIPS reporting, STS does not specifically have a measure or anything that's going to affect your star rating for this particular variable. It's a MIPS measure. It's measure 358, patient-centered surgical risk assessment and communication. And for those of you who aren't familiar with MIPS, MIPS measures are performance indicators used by Medicare to evaluate quality, improvement activities, cost of healthcare provided by eligible clinicians. It's an original reporting option is available to clinicians under the Quality Payment Program. And so it's a Medicare initiative. So STS, again, doesn't specifically have a measure or a metric for this. It will not affect your star rating. It could and will affect your MIPS if you do MIPS reporting. I just wanted to clarify that because that's a common question I get. Next slide. Okay, here's another really common question. If the physician documents in his or her narrative that the STS risk calculator was discussed with the patient, does this cover the field as yes, or does the actual calculator and score need to be in the chart? So this is a very common question, and the answer is you don't actually have to have the actual score for the breakdown. You know, the intent of this whole field is to see if the physician had a discussion about the STS risk calculator score that he did or she did, and was it discussed with the patient or the family prior to surgery. So the surgeon does not have to specifically say, I calculated this STS risk calculator and the score was 8. Okay, you don't actually have to have the actual score. For example, you could say, the surgeon could say, the STS calculated risk score was discussed with the patient and the family. And you can see from here that he's calculated or she's calculated the risk score and they discussed it with the patient family. That's acceptable. The second example, the Society of Thoracic Surgery Predicted Risk of Mortality and Morbidity, PROM, was discussed with the patient. His predicted STS risk of mortality per the STS risk calculator with elective bypass was 1 to 2%. So this particular surgeon, not only did he tell you he discussed it, but he also gave you the score. So you can do it either way. The third example, I have discussed risk and details of the planned procedure with the patient, including the STS risk stratification per the STS risk calculator. So example 1 and 2, they're still acceptable examples, even though you don't have the actual score, because the surgeon or the provider talking to this patient documented that they discussed the STS risk score or risk calculator score with the patient. Next slide. Okay, so I'm just going to go through some examples of what I think is really good documentation because I get questions like this all the time. number one is like, and number two, these two examples are like perfect examples. So patient was seen and examined at the bedside. The patient's chart and all data was reviewed. The procedure, treatment alternatives, risks, benefits were explained. The specific risks discussed. The STS risk calculator score was discussed with the patient family prior to surgery, where applicable. After discussion with shared decision-making, an agreement has been reached to proceed with the valve, aortic valve replacement or repair. That's a perfect example. It's very clearly defined that this provider discussed the STS risk calculator score with the patient and the family. And he did it prior, or she did it prior to surgery. That's another thing. It's got to be done prior to surgery. Okay, a next example of some really good documentation. I have calculated an STS, Society of Thoracic Surgery, risk score analysis for the patient and explained the risk, benefits, and alternatives with the patient. And then the surgeon goes on to talk about the risk. But again, it's very clear in this documentation that this particular provider calculated the risk score and they talked to the patient about it. So those are excellent examples of documentation. Next slide. Okay, so let's talk about some non-acceptable documentation. Because remember, the intent here is to indicate if the STS risk calculator score was discussed with the patient and family prior to surgery. So the surgeon or the provider needs to reference the STS risk score or calculator in their discussion. Okay. So here's the example. Indicated for urgent CABG. All the benefits, risk, and alternatives were discussed with this patient. Patient shows understanding verbally, agrees to surgery. The benefits of surgery were discussed in detail, including but not limited to relieve the current heart-related symptoms, improve life quality, potentially prolong life. All the risks were discussed, including but not limiting to perioperative stroke, heart attack, hemorrhage, infection, kidney failure, yada, yada, yada. He's going on, but nowhere in this documentation does this provider mention anything about the STS risk calculator score at all. So this is an example of non-acceptable documentation. You've got to have some mention of that in the discussion and the documentation. And it has to be discussed with the patient or the family if the patient's unable mentally wise to understand what's going on. Okay, next slide. Examples of non-acceptable and acceptable documentation in the same patient record. Okay, so you've got, this is the same patient, but we've got two different kinds of documentation going on here. So the first one is the PA documented the STS risk, morbidity, and mortality, 7.52% in his note. This is the only documentation he did. Okay. So this is not acceptable. You've got a score, but you got no discussion with the patient. Okay, so if this PA had documented the score and then went on to say, I talked to the patient about this, you know, we discussed it, yada, yada, then it would be okay. But just documenting the score, that's not acceptable. However, the surgeon came in later after the PA, and the surgeon said, discuss the STS score calculation with the patient and how it is one component that is incorporated in the overall context of the perioperative risk assessment. So the surgeon came in and said, hey, I discussed the score with the patient, and it was the STS score calculation. And so this is an acceptable. So in this particular patient record, same patient, two different sources of documentation. One is not acceptable. The other one is. Because remember, we have to have some mention that the STS risk score or the risk score calculated or risk calculator was mentioned, and it was discussed with the patient in order to say yes to this measure. I don't know if that's my last slide or not, Nancy. I think it is. Okay. Thank you.
It is. So let's, we'll move on to questions, but I'm gonna take the questions about the STS risk calculator first because it's fresh in our brain. So Laura is asking, is the language STS risk discussed with the patient acceptable?
I think you have to have more than just STS risk. If you had said risk score or risk calculator, because, you know, what does that really mean? What does STS risk alone really mean? You know, I think if the doctor had said STS risk calculator or risk score discussed, it would have been okay.
Okay. Is the STS risk score discussed an audited field?
I believe it's so. I think I'm right on that. Right, Emily?
What
believe
is,
so.
can you tell me, do you by chance know the number?
1966.
Yeah.
I feel sure it is.
Not for this year.
Oh, not for this year. So it has been in the past.
It has
but,
been in the past, yeah.
Yeah, but not this year.
What if the calculated score is in the chart and the surgeon states they have discussed a risk with the patient, but they don't specifically refer to the STS risk calculator score discussed?
Okay, so when people send me questions like this, Lindsay, I say, send me the screenshot, because sometimes you have to look at the context. So like if the surgeon has a whole note, you know, where he's doing the consult and he's put the score in his note, and then, you know, the very next paragraph is how he's talking to the patient about it, right? It's kind of a gray area, but I think if you can associate, I mean, if you have the score in one note and the discussion in another note, no, that's not going to work. But if they're in the same note and you see that the context is flowing, that he's presented the score and now he's having a discussion with the patient, or she's having a discussion, I always say, send me a screenshot when we that, and we kind of work through that one together, because those are more difficult. I also tell people, this may be kind of borderline, and it would be really nice if you could work with your providers to say, I've discussed the risk score, the STS risk score with patient, to make it a little more solid as a process improvement project there. Those are difficult ones. They're little tricky ones.
So Sheena is asking, if the calculator does not affect star rating or STS ratings, why do we need to collect this specific information? Does MIPS specify that the STS calculator needs to be used, or does it meet the MIPS measure by them stating they discussed risk and providing percentage of risk?
Do you want me to take that one, Nancy?
Yeah, go ahead, Carol. I'm
Okay.
thinking through it.
Yeah, I'm pretty sure it's related to MIPS or other payments where shared decision making is one of the measures that they use from the STS, looking at the risk calculator discussion.
Yeah, you know, in the past we used to send MIPS data in, remember, Carol?
Yes.
And so we, and this is kind of when this whole thing, I think, evolved, the whole question and the sequence number and everything. But since then we don't actually transmit MIPS data anymore, but the site can transmit their MIPS data by using the risk calculator, our STS risk calculator. I'm not a MIPS expert, but maybe somebody on this phone is, that knows a lot more about MIPS than I do. But it does help satisfy the MIPS measure for those who do MIPS reporting.
Kelly asked, do you see a future where the practitioner can click the proposed procedure and it populates the fields for the risk score? The practitioners have expressed great confusion on the many calculators now.
Click the proposed procedure and it populates the fields for the risk score. Oh, I see what you're saying. I don't know, Kelly. Sounds like a interesting concept, though. What do you think, Nancy and Carol? It's interesting.
Yeah. I don't know. There's lots of innovations coming, so I don't know. Carol?
Yeah, I don't know. We're not super involved with the risk calculator development.
Yeah.
I think there's, Kelly, I think there's email on the bottom of the risk calculator page that goes to the research center, the STS research center, that you can send in that type of feedback to them.
Oh, that's a great idea, Carol. Yeah.
All right. Could you please explain how a procedure without a risk model can have a risk calculator? Are calculators not based on the model?
Calculators are based on the model. The model might not be implemented into analysis because of a low N. So the risk calculator is based on a risk model. That's how we come up with the expected rates or expected percentages. But things like if we're looking at, do we have a calculator for multi-valve?
Mm-hmm.
That calculator, we produce that in analytics, but we don't have a star rating on that because of the low number of cases. The other one, like
The aorta one, we don't.
yep, the
we don't have.
aorta one, we don't have that implemented yet. That is based on the risk model. That's how the calculators get built. And it will likely be implemented in 2026 into reporting, but we won't have a star rating that I'm aware of yet for that one because of the lower N. And then I think what's the other one?
The tricuspid one.
Oh yeah, we'll never, it'll be unlikely that we'll ever report out risk adjusted data specifically for tricuspid because of the low N. But they want to give the surgeons at least a tool that they can use for discussing risk with their patients. That's why those calculators are available.
Thanks, Carol. Thanks, Melinda. What if they have a scan of the risk score right beneath the example
You
that you
just showed? Which example?
Mm.
Sue, which example was she talking about? I don't know. Nancy, go back through the slides. Sue, like, we can kind of go back through the slides and maybe you could send us a heart or a thumbs up or something. Not that one. Not that one. Or she can unmute herself and tell us, or we can unmute her.
Yeah, let's see.
Just found her and clicked allow to talk.
Yeah, can you hear me? This is Sue.
Oh, yeah. Hey, Sue.
Yeah, so typically I'll see that they do an actual scan of the risk score and then, they have the elements that went into that and then it's attached to the note that says the risks were discussed. So the note doesn't specifically say, the calculated risk score, but below they've got the information and it's all in one note per se. So
That's what I'm saying. I think that those that are in the same note.
yeah, I just wanted to clarify if it was a scan, that'd be the same way.
I mean, you can see it's the same context. They got this calculated and they're talking about it. I think those are okay.
Okay, great.
Especially if you can associate that it's the same context. It's the same note,
Okay, appreciate it. Thank you.
Okay.
Thanks, Sue. And then Brianna, you can unmute.
what's her name? We have to allow
Brianna,
her. Brianna Hill?
I did.
Okay, good.
Right.
Looks like she's on twice.
Yep. Oh,
Okay, both of them are on. There you go.
Brianna, can you unmute yourself?
Maybe, maybe not.
Okay. All right. Brianna, if you can unmute, just let us know. We'll continue on with the questions. Let's see. Neil, for the risk score, is note shared with patient acceptable documentation of discussing the score?
I'm not sure what I understand what you're describing there, Neil. If you want to unmute and describe it more, or you could send me an FAQ just to clarify. Not sure exactly what you're saying. Sorry.
Oh, here's Neil.
Hear me?
Yeah.
Hello?
Go
Hi.
ahead.
Okay. It's usually we'll have a note on the case where they've got the entire breakdown of the risk score, the STS risk score. And at the bottom of that note, there's an indication that the note was shared with the patient. Is that sufficient to indicate that they discussed that with the patient?
Is this a pre-op note?
Yes.
So it's like a consult note, right? Or something like that.
Yeah.
I think that would probably work. Maybe you could send me a picture for sure, but I'm trying to visualize it in my head. But I think if it's in the same note and they have all the scores and then the physician or provider just says they shared the note, the note's kind of hanging me up, but I think that if they're referring to that calculator in as the note, then it probably works. But maybe the language of that needs to be a little bit better, like shared risk calculator with the patient or something. Do you know what I mean?
Yeah. Yeah. I think that this might be something that's baked into the cake with our Epic layout. So I don't know that that particular wording can be modified. They wouldn't probably, in order to modify it, they would just need to add an additional statement. I mean, it would be a little bit redundant, I would suppose, but
I don't know.
yeah.
I'd like to see it. Maybe send me a screenshot because I've not seen this in Epic. Nobody sent me something that looks like that. So I'd be interested in seeing it.
Sure, absolutely.
Oh, thank you so much.
Thank you.
Thanks, Neil.
Thank
And
you.
then I'm not sure, SBMT2, you can unmute. All right. While everyone's getting unmuted, we'll move on. Regarding the STS risk calculator discussion, will we get dinged if we answer yes when a discussion was had, but the status changed at the last minute, or the operation started off as one model but changed due to unsuspected? Question moved, sorry.
Disease or anatomy? No.
Yeah.
So the risk calculator discussion occurs pre-op. Okay. So, and it's based off your planned surgical procedure, right? So if you're planning to do a cabbage, then you would use that calculator, the ACSD calculator. You discuss that with the patient, and then you get into the operation, and all of a sudden something bad happens and they have to repair a ventricle or an aorta. No, that wasn't the planned surgery. That happened after you went to OR. So you talk about the calculator of your plan procedure prior to the operation. That's the calculator that you use.
Thanks, Melinda. Natalia says, excellent clarification. Thanks, Melinda. So the effective date for the newer categories of risk calculators is June 1st. Example, a sending order replacement done on 5/31 would be not applicable, but the same procedure on 6/1 would be a yes if all documentation meets the standard.
Sure, but keep it in mind, there's no metric for this. There's no measure for this. So we've made a change. We made it effective June the 1st. So moving forward, this is the expectation. But again, there's no measure, there's no metric, there's no effect on your star rating. So don't get too bent out of shape or stressed out. Just kind of move forward.
All right, and Adita, I've got that slide up for you with the examples of excellent documentation. Darlene is asking Neil if the Epic tag note shared with patient, or is it specifically documented by the provider?
Good idea. Good point, Darlene. I don't know, Neil.
Then,
Can you say that again?
Neil,
I'm sorry.
yeah, Darlene is asking in that Epic tag note shared with patient, is that an Epic tag or is it specifically documented by the provider?
I believe it's an Epic tag.
And then Erica, the note being shared is standard verbiage of the Patient Information Act in which patients have access to notes.
Oh, that's interesting. That's why I want to look at this one for sure, because that's interesting.
Yeah. And then Beth says, I wouldn't think sharing the note would qualify for discussing the score.
Yeah, that's I don't like that language very much myself, Beth, which is why I suggested changing it. Plus, I wanted to see it because there's something about
Yeah.
sharing the note that makes me nervous.
Yeah. All right. So Neil, if you would just share your note with Melinda and then, or share that note with Melinda. And thanks, Erica and Beth, for your feedback.
Mhm.
I will do.
Thank you. In my vendor software, I click on calculate risk after data is entered and get scores for current cases. My vendor doesn't have information and the newer categories of risk calculators are not available. Should I lose sleep over this?
I can answer that one.
All right.
No, it's not giving you the score, but, and that is coming very soon. We are working, the vendors are going to actually be tying into the risk calculator, and the risk calculator is going to be doing generating the scores for you, and that will pull it down. So like when you save the case, and in this case, like where I was seeing somebody else saying you have to hit the button to say, give me the risk scores. It's going to reach out to the risk calculator and get all of the scores from the risk calculator. So you're going to start getting it with the latest coefficients, and it's going to be exactly the score that's STS is going to use in analysis because it's being calculated by STS. So that's coming very soon. We don't have a concrete timeline yet, but it's as of this morning making good progress. So we're getting there.
But Jean, all the risk calculators that we talked about are available in the STS website for your providers to use currently. If they choose to use those to discuss the risk based on the calculator for the patient.
Judy, would you be willing to send an email to surgeons to let them know that we need to be collecting the new calculators? It's such a change for them. Judy, I believe whenever the new calculators were updated, the surgeons were notified. Are you asking for a new email to let them know that this is part of sequence 1966? Guess. Judy, I'll investigate that and email you. Oh, Paul, can you explain again about STS
Sure.
calculating risks by the
Yeah,
risk by the vendors?
so right now, what the vendors do is they were given a copy of how to calculate the risk scores, and this was back when this data version first came out. You're talking about 2020, so quite a while ago. So they are using that, but they only have the old risk scores for the old proc IDs, and they're using the old coefficients in that. When in the near future, we're going to give the vendors instructions on how to call the risk calculator, get the scores for you, and populate it into those fields. And that will include the multi-procedural scores. And that is that's coming soon. I don't, that's best I could tell you. I can't say exactly when, but within the next couple of months, we should be getting that out to you guys.
And is that the same process as the direct data entry participants?
Direct, actually, that's a good question. How would the direct data entry? I would think so, that the direct data entry people are going to, well, the risk scores are not, direct data entry people don't see the risk scores, do they?
Mm,
Yeah,
not sure.
I don't think direct data entry people can see the risk scores. In any case, we're also still doing the process of when we do the data harvest and we get ready to do analysis, all of the risk scores are going to be recalculated by STS right before doing analysis. So that part's not changing. And that's basically where the direct data entry people, that's how those risk scores get calculated. But I'm not sure whether the direct data entry people are going to see the new risk scores or not. I don't know.
Thanks, Paul.
Mm-hmm.
We can try and get an answer for you, Laura, and follow
Yeah.
up.
Mm-hmm.
Yeah, there was another
Yeah.
comment about direct data entry.
Yeah.
They don't see the scores. Yes, it would be very
Yeah.
helpful to see them.
I would think so.
Yeah. All right. Let's go grab some of these other questions from the top. Is there any plan to bring back the ctsurgerypatients.org patient website, or is that website gone for good? Shuli, I'm not familiar with that website.
I can take this one. Hi,
yeah.
Shuli, it's Carol. The website, it sounds like, is gone for good.
Mm.
I'm sorry.
And then, did you have something else, Carol?
No, I was just saying to Shuli that the website is gone for good. The reason we took it down is because it wasn't getting used. It wasn't being accessed very often. And what we've heard from our surgeon leaders is that they were using the sites were using their own internally developed patient information to share with the patients. So sorry, it's gone.
Julie's asking the projected time frame for aorta procedures to be analyzed. I believe that's,
Oh, go ahead.
I believe it's 2026. Is that correct, Carol and Paul?
Yeah, that's my understanding. Well, we were looking at Harvest 1 2026, but it might be more like Harvest 2 or 3. So just waiting to get the timeline nailed down for 26, but it will be coming next year. And it will be risk adjusted results, just like the multi-valve is risk adjusted results, no star rating to start.
All right. And then Marina's asking, what is the rationale for including a multi-procedural composite score?
I can take that one too. It gives a larger N for your site, so you have a better idea of how your site's truly performing across your cardiac surgery area.
And then Sheila is asking, what are the weight percentages of the domains for star ratings for multi-procedural? And the procedures that make up multi-procedural are weighted as per the weight of the individual procedures. So your cabbages will be weighted like a cabbage and your valves will be weighted like a valve. Surgeons are asking for more of an explanation of how the multi-procedural composite scores are calculated, especially since the distribution of sites and star ratings is very different. That's kind of pertains to the weighting. So each procedure that's contained within the multi-procedural composite is analyzed according to the risk model for its risk model. So the cabbage cases within the multi-procedural composite are risk adjusted like a cabbage. The valves follow the valve model. Valve plus cabbage follow that risk model, etc. So that's how that is calculated. Does length of stay contribute to the star ratings? No, but you do have risk-adjusted results related to short length of stay and long length of stay. But that metric does not directly contribute to the star rating. Will congenital have exceptional risk one day? I can say that the other databases are interested in exceptional risk. I don't know of any timeline or anything as to when that would be implemented for congenital or thoracic. But the other databases are certainly interested in having that for their databases. I thought exceptional risk exclusion cases were for star rating eligible cases. Is it just the isolated cases? So the isolated cases are star rating cases with the exception of the multi-valve. Exceptional risk exclusion is submitted prior to surgery, so the V number will not be generated in our vendor unless it's been entered. You don't have to provide the patient ID and record ID until the patient has been entered. You can send that to us once you get the patient into the database.
But I would think you would have something. I mean, unless the patient's being pulled in from a ambulance and you're running them into the ER, you know, you've entered demographics that gives you the patient ID. If you can, you're putting in risk factors that would give you your operation ID or record ID. So,
What's the question?
The question
Then-
was the patient ID and record ID aren't available, or since the exceptional risk cases have to be submitted prior to surgery, we don't have the patient ID and record ID.
Yeah, that's okay.
Yeah, we don't need that until later in the process, so
Yeah.
can send it when it's available.
It has, Sue's saying that it has to do with the risk score. We don't need the risk score for the patient to have a review a case for exceptional risk. I think that's what she's saying.
Julia has a
I'm not
question
sure.
about, is there a shorter data collection version for aorta repairs? And then a second question, if a patient only had a CT coronary angiography, can I use it if no cardiac cath is available or not done? We have some forms, the surgeon worksheets on the website for aorta cases that your surgeons can fill out for you to make that aorta obstruction shorter for you. And then as far as the CT coronary angiography, if it gives a percentage of stenosis and there's no cardiac cath, I believe you can use that for your data collection.
Mm-hmm. Yes, you can. If it's really a coronary angiogram, not just a straightforward CT.
All right. If there is no echo within a year, how do I code 1585 through 1822? I understand when an echo is done and there's no documentation on stenosis or regurgitation, we mark no. Do we code the same if there is no echo within the time frame?
Just say no. There was no echo.
Then for multi-procedural, just to clarify, does the multi-procedural composite include all risk models involving multi-valve and multi-valve plus cabbage and not necessarily a specific risk model for cases for multiple procedures? So yes, all of the cases that are included in multi-procedural, each of the separate cases follow their own risk model. There is not a separate risk model for multi-procedural. Any update when the risk scores will be available for the new models? We can't see them in PATS. I think Paul answered that earlier. That is coming up soon. We're still working on getting that for the vendors. Let's see. And then what is the holdup for giving the vendors access?
We're working on it.
Yeah.
I mean, the first thing is, it needed to be programmed first and made available, as well as all the other calculators. It's the same team doing all of the calculators. And now we have to modify it to make it so that it works for the vendors, so that the vendors can call it automatically for you. So there's some updates that need to be made. So that's one, it's getting time on the developer's calendar, and then also making sure we figure out everything that needs to be changed on it, programmed so that it works for the vendors. So
That's why this group is so wonderful, because they just ask the questions. What's the holdup? What's going on, Paul? Why is it taking forever? Sounds like Nancy and I asking the questions.
Oh, and then I think we just have some clarification here. The risk score calculator is to be done by the provider prior to surgery. The risk scores in your vendor software are made available after the case has been abstracted.
Correct.
Correct. Can we use the anesthesia echo if no other echo in the last year?
Oh yeah, there's priority. I mean, either the patient had a pre-op echo, yes or no. If they didn't have a pre-op echo, then you can use the pre-intra-op TEE results if you don't have anything else. So I thought when I read that last question that the patient had no echo, period. So.
All right. And then Trish is asking a question about exceptional risk. If the initial form for exceptional risk is submitted and the surgeon changes his or her mind regarding the request, it cannot be retracted. Is that correct? Yes, Tricia, that's correct. Once the case is submitted, it must move forward with our exceptional risk process. Mary says, great topic. Thank you, Mary. And then Alicia had a case with no echo at all. So you would just answer no?
Yeah, I would.
Alicia. So Maria says if the patient has been placed under anesthesia, I thought we were unable to use it. The echo.
If you go to the training manual and you look at your source document priority for coding, so your first source is our pre-op studies, right? Done within 6 months or can be up to a year. Your second choice is if you've got nothing pre-op, no echo, then you can use the pre-op, pre-incision, intra-op TEE, okay, in that particular situation. It's very clearly laid out in the training manual for capturing the hemodynamics prior to surgery.
All right. And then regarding the intra-op, pre-op echo, you can use it as long as it's prior to skin incision. Is that correct?
If you have nothing else
If you have nothing else.
pre-op, or, you know, you can use it if your surgery changes, right? So there's very clear guidelines in the training manual. Maybe we'll talk about that on another call.
Yeah. And then one more question, Melinda, about echoes. Why can't we code no for valve regurgitation post-op if the regurgitation was not specifically addressed?
I'm assuming I don't know which field you're specifically talking about, whether it's the post-intra field for that or the post-op field. I think we have a not documented choice.
Yeah, that's what I'm thinking. I'm trying to look.
I'd have to look at it specifically, but I think
There's a
we
not documented option for that.
yeah. So if it's not addressed, then we would code not documented.
Yeah, and thank you, Heather. Yes, thanks. And then why not code pre-op, not documented pre-op to keep it consistent?
Because of the parent-child relationships.
Mm.
I'll just say it that way. It's different. There's a different mechanism going on there.
Yeah, sounds like we could probably do some additional education on that on a different webinar. And then we just had a comment about the risk calculator, that it's kind of difficult to use. Thank you for that feedback.
We should send that to the research center. The
Yeah.
feedback, like we suggested earlier.
All right, we are at about 17 minutes over. It's just one more echo question. There's not an option to say no for echo done, only if EF done. All the other echo fields end up being left blank.
No, you don't leave them blank, Joelle. If we have pretty good instructions in the training manual. So if you don't have a pre-op echo, so you have no information on regurgitation, stenosis, those things on your valves, or EF, you just say no. Okay. And you can send me a question and I'll point that area in the training manual out to you. Happy to do that.
And then this will be our last question. How does beta blocker pre-incision coded as contraindication affect the medication domain?
Well, it's removed from the denominator.
Yep.
It's excluded from the metric. It's contraindicated.
Right. All right. Sue says, great meeting. Thanks, everyone.
And I'm
Um,
glad to hear Pam said I said note share
Oh.
with patients not acceptable. I didn't think it would be. She must have sent it to me and I forgot I saw it. I get a lot of questions, so I apologize for that. Not remembering that, Pam.
All right. Well, thank you everyone for joining. We'll see you, I guess, again on July the 16th for our next webinar. Thanks, everyone.
Thank you, Nancy, Carol,
Thank
everybody,
you.
Emily.
Yeah, great job. Thank you, everybody. Thanks for joining too, everybody.
Thank you all.
Thank you.
Thanks, Paul.
Thanks, Paul.
Always so helpful. Bad news. Bad news, Paul.
That's me.
Just kidding.
Got to stir the pot.
Yeah.
Right.
Great call. Thank you.
All right,
Bye.
thank you, everyone.
Thank you. Bye,
Bye-bye.
everyone.